This has been a rapid fire review of women's health, and I'm going to bring us home with some menopause, which I would like to argue is relevant to all of us, regardless of where we're going at the end of this. So I do not have any disclosures other than I would like a job where I can discuss menopause at the end of residency. To start out, I'm going to review our learning objectives. We have a couple of them today. The first one is we're going to learn how to define menopause. We will identify common symptoms of menopause, and then we'll really get into the nitty-gritty and determine some treatment options for common symptoms of menopause. And last, evaluate the safety profile of hormone replacement therapy so that you feel prepared to answer questions from patients about safety. To start us off, we're going to review a case. So we have Flo, who's a 46-year-old woman coming to clinic complaining of trouble sleeping. She states that throughout the night, she wakes up 3 to 4 times with sensations of full body warmth that is so severe she gets out of bed as to not disturb her partner. Associated symptoms include racing heart and sweating. These episodes also occasionally happen during the day. She's also felt more irritable. So let's talk about what menopause is. I think these definitions are really important in order for you to kind of understand where the patient is and how to best counsel them through this really tumultuous hormonal time in their lives. So perimenopause is kind of the first term we're going to talk about, which is the time from the first irregular period to 1 year after the final menstrual period. And this can last, multiple years for most patients. And then menopause is determined retrospectively 1 year after the final menstrual period. And this, on average, in the United States happens between age 51 and 52, but it can happen earlier and later. Many people I talk to say, how do we diagnose menopause? Can we get some labs? We're internists. We love labs. And I just want to highlight that menopause is a clinical diagnosis, and we do not need labs to, quote, diagnose menopause. But since we're all curious people, let's talk about some of the common labs that we get in order to evaluate fertility or perimenopause. The first one I'd like to talk about is FSH, which is an indirect measure of follicular reserve. When it's lower, it's more encouraging for conception. And when it's higher, it is more suggestive of perimenopause or menopause. Here, the source that I had said greater than 70 is menopause. I've also seen greater than 30, but the idea is the higher it is, the closer you probably are to menopause. However, it's not a great predictor of how long it will take to get to menopause. The other marker that is commonly measured is AMH, which is a direct indicator of follicular reserve. And if it's undetectable, it predicts that the final menstrual period, that's FMP, has happened or is going to happen within the next year. And if it's greater than 200, it means the FMP is more than 5 years away. So the way I find AMH most useful is actually for patients who are kind of in the same age range as Flo, our case patient, who's 46. It's not completely clear what's going on with her. And we want to predict not just her long-term, like how quickly will she go into menopause, but also what are her conception or contraception needs in that time. And we're not going to get into contraceptive options in too much detail in kind of the later reproductive years, but just know that this is actually a tool that can be useful for that. So what
Nikki,
symptoms? Yeah, go ahead.
Cody asked a good question just about what about patients who have hysterectomies but still have their ovaries? Like, how do you know when they're going through menopause, or is this when the labs are important?
That is a fantastic question. I think that these labs can be more helpful in this situation, but at the same time, acknowledging that the symptoms are kind of the classic starting point for menopause. And as long as they have their ovaries, they'll still have these symptoms of estrogen deprivation. And so sometimes the labs are helpful in a patient who's like 53 and is like, have I done it, doc? Like, am I through menopause? I think that can give us some more information, but obviously it's a lot more nuanced in someone who's not bleeding. I'm not sure if any of the other women's health residents have thoughts about that. So what symptoms do we see in menopause? There are some that you've probably heard of or talked about in the, oh, sorry, Cody, I'm looking at your chat. I found at times it is tough to know with patients based on symptoms anecdotally. I agree. And then we're also going to talk about how these symptoms can persist past the classic menopause time. I think to really clarify, what are they hoping to get out of knowing whether they're in menopause or not? And if the symptoms are what's bothering them, regardless of kind of the stage they are, perimenopause or postmenopausal, we kind of treat patients similarly. So I think that to kind of better understand the patient's goals out of lab testing helps guide my counseling. So what symptoms?
Hillary has another similar question, is just if they're on contraception. I don't know if you're going to get there. Like,
yeah, that's another fantastic question. You guys are asking all the good, complex menopause questions. So this is really hard, where we're going to talk about HRT, and cyclic hormone replacement therapy also promotes bleeding. And so often, I think it really depends on the type of contraception. Some people have people be on, like if they're on OCPs, be on OCPs until age 50, and then switch over to hormone replacement therapy. Some people do it longer. Some people have an IUD stay in all the way. And the women's health residents got a lecture a few weeks ago about menopause, and she recommended counseling patients like, maybe we should take you off of your contraception, see if you're still bleeding regularly. But I think that it's very provider dependent about what the best option is. But you're right that withdrawal bleed on continuous oral contraceptives is not the same as a period or a menstrual period. And so we can't use that to predict bleeding risk or bleeding kind of patterns. Any other questions right now? Thank you guys for asking such good questions. So I want to make sure that we talk about common and uncommon symptoms of menopause. Some of the most commonly discussed symptoms are the ones that we think about due to this hormonal chaos, and the hormonal changes in menopause are comparable to the hormonal changes experienced in puberty. So it's very dramatic. This hormonal chaos is hot flashes and night sweats experienced by up to 80% of women, sleep disturbances, anxiety, depression, mood changes, and changes in cognition. Due to estrogen deficiency or the loss of estrogen, we see the genitourinary syndrome of menopause, so vaginal dryness, pain, urinary symptoms. And then we're not totally sure about some of the other conditions like joint pain, changes in body contour, and low libido that we also see as part of menopause. But I bring up these really diverse symptoms to remind you all that it's really important for you to know the common symptoms of menopause so that you can adequately counsel your patients and provide anticipatory guidance. Many of these things are not really commonly discussed in our society, and I think telling patients that these things can be very disruptive but are normal and common can be very reassuring to people rather than kind of them suffering alone. Okay. So what types of symptoms at what frequency do we see in menopause? Like I said previously, the most common symptom is hot flashes, but we also see night sweats and disrupted sleep at very high rates, and then mood symptoms, fatigue, weight gain. You can see here that less than 1% of patients experience no symptoms related to menopause. And so I think that's really important to remember, that when you see a patient between age 45 and 60, the overwhelming odds are that they have experienced or are experiencing symptoms of menopause that significantly impact their quality of life. And it's important for you to bring those up to help counsel your patients and help keep them comfortable. So back to our case. In addition to Flo's nighttime symptoms and irritability, she's been noticing mild weight gain, which she attributes to the pandemic, and fatigue. She also says her periods are becoming more irregular and now are happening every 6 to 8 weeks. She's 46, if we can recall, and she asks you, is this menopause? Aren't I too young for that? What do you have to say to Flo? How would you answer Flo's question? Someone can just type, either speak out loud, there's not that many of us, or type in the chat. It's okay. I would say that she is in perimenopause. Yeah, good, Anna. That she, given that she is still having periods, even though they are more irregular, I would put her in that perimenopausal category. And what about which symptoms are consistent with her kind of perimenopausal condition? Really everything she's experiencing, right? Good, Roxanne. Her nighttime symptoms, mood symptoms, weight changes, fatigue, irregular periods, all of that really encompasses her this perimenopausal time. And it's not to say not other things could be happening, but if you do, your thyroid workup and your iron deficiency workup, and it's all normal, we can say that these symptoms we likely are attributing to menopause. So this is the takeaway number one that I want you guys to take away from this talk, which is that symptoms of menopause are diverse and extremely common. And this is a fantastic image from a Nature Review primer on menopause that talks about the CNS symptoms, the skin symptoms, sexual function, genital symptoms, weight changes, musculoskeletal system. And that's really, it's incredible, the diversity of symptoms that are experienced. I want to take a moment to highlight Molly's comment about differences between natural menopause and surgical menopause. And I don't know exactly kind of how this has talked about those kind of less understood symptoms, but generally speaking, surgical menopause is much more severe. And they experience a lot of these symptoms at much more severe kind of ways. And so that very dramatic change in estrogen might explain some of the variability in symptoms. So I now want to transition into a discussion of treating some of the most common complaints. And I really am going to highlight two different symptoms. One is vasomotor symptoms, and the other is GU symptoms, which is broadly characterized by the term genitourinary syndrome of menopause, or GSM. But first, we're going to talk about vasomotor symptoms. And as previously discussed, vasomotor symptoms are one of the most common symptoms of menopause. They can begin 2 years before the final menstrual period and peak 1 year after the final menstrual period. They usually start to subside about 4 years after the FMP, but in more than 10% of women, they can persist for up to 10 years, if not longer. And you can see them both at daytime and nighttime, just like our patient, and they can play a role in the sleep disturbances seen in menopause. These are due to estrogen withdrawal, and they think it's related to changes in thermoregulation at the hippocampus, or the hypothalamus, I'm sorry. And like we said previously, surgical or induced menopause has more severe symptoms. I want to move right into talking about the best or most effective treatment option for hot flashes, which is hormone replacement therapy. And before we talk about this, I think it's really important to say that menopause is not a disease. It's a natural thing that happens to us as we age and does not require treatment unless symptoms are bothersome. And this is when that patient-centered care is so important, of saying kind of, how is this impacting you? Because some people can really cope with these well, and some people it impacts so many parts of their life. But talking about hormone replacement therapy, it's FDA approved for the treatment of moderate to severe hot flashes. And that's actually the only menopausal symptom that it's FDA approved for, although it is used for the other symptoms of menopause as well. We'll talk more about the safety profile in a bit, but it's safest for women under age 60 and within 10 years of menopause, and it's highly effective. It's really important to not use HRT to prevent things, like in this kind of classic menopausal patient, not someone with early surgical menopause or breast cancer, things like that. But in the average 50-year-old, don't use it to prevent osteoporosis or coronary artery disease or dementia or things like that. Use it to treat hot flashes. And how do you prescribe it? The backbone is estrogen therapy, estrogen replacement, and then progesterone is added back depending on the patient's, the presence or absence of a uterus. And there's multiple routes of delivery. We won't go too much into dosing and things like that, but to know that there are many ways to deliver both the estrogen and the progestin that can be in line with the patient's goals. So how is HRT given? If a patient does not have a uterus, meaning they don't have an endometrium, it is safe to give continuous estrogen therapy because without a uterus, there is no bleeding risk. However, if a patient has a uterus, then we are concerned about the risk of endometrial hyperplasia with unopposed estrogen therapy, and therefore we need to add a progestin or a progestogen, which is a broad term for progesterone, in order to promote, to decrease the risk of endometrial hyperplasia. There's two different ways we can do this. One is continuous sequential HRT with continuous estrogen therapy, and then progestin therapy for 7 to 14 days. When you discontinue that progestin, then it leads to a withdrawal bleed, just like an oral contraceptive. And the other option is continuous combined HRT, where you give both an estrogen and a progestin combined without a break. And that is when there's no bleeding at the end of the cycle. Generally, I've found that patients prefer the combined HRT because that continued bleeding can impact kind of their life. Can you do an OCP? OCPs are actually at fairly higher doses of hormones, and HRT is at a lower dose. And so it's generally considered safer with a better risk profile to do HRT rather than OCPs. I hope that answers your question. Yeah, so Terrence, we will talk about some other options about treating vasomotor symptoms, but know that HRT can be given in that perimenopausal period. So that's this idea of saying maybe around age 50, 51, if someone is still having periods if they're on an OCP or something like that, it's okay to start HRT before menopause. So this can be used in that perimenopausal period. People on OCPs will also notice, since you're providing that exogenous estrogen, will likely have fewer night sweats, fewer menopausal symptoms. But the goal is to switch them to HRT when they feel ready, because it's at that lower dose and is considered safer than an OCP. And I think the important question is, does it work? And the answer is really yes. This is a fantastic graph comparing hot flash frequency and severity to patients on hormone replacement versus a placebo. And you can see here that there's a statistically significant difference at both 4 and 12 weeks in both frequency and severity of hot flashes. So this is a highly effective form of contraception. So now you're probably like, wow, all these menopausal patients should be on HRT. Why don't we do that? And I want to bring up the contraindications to HRT. So who is not eligible? And you'll notice this list is different than OCPs. And I think that's something that I didn't completely realize, but more people are eligible for hormone replacement therapy than those who are eligible for oral contraceptives. So the absolute contraindications are a history of breast or endometrial cancer, established cerebrovascular disease, so coronary artery disease, history of a stroke or TIA, peripheral artery disease, active liver disease, and then undiagnosed vaginal bleeding, which makes sense due to that concern for unknown endometrial hyperplasia or metaplasia. Relative contraindications, we've touched on a couple of them. One is age greater than 60 or menopause greater than 10 years ago. And that has to do with some of the safety profile that we'll talk about shortly. The other relative contraindications are patients who are at high risk of CVD. And this even includes people maybe with uncontrolled diabetes or those who are on a statin with hyperlipidemia. I think this is when that risk-benefit analysis with a patient is really important. And then patients who are at a high risk of breast cancer or those who are smoking more than 15 cigarettes a day. And Roxanne brings up a great point that patients with non-hormone sensitive breast cancer are eligible for HRT. From our experience, many of them are not comfortable being prescribed HRT due to the slightly increased risk of breast cancer over time. And I would probably have those patients discuss it more with their oncologist just to discuss their specific risk. So what about patients who are not eligible for HRT or don't want HRT? HRT because they've heard about the risks or the side effects and are concerned about those. There are a number of treatment options that you as an internist might feel more comfortable prescribing, or the patient might be more comfortable taking, that are also effective. One of the biggest buckets is SSRIs or SNRIs. And many of them have actually been shown to be quite effective, with paroxetine, duloxetine, and venlafaxine having a 60% reduction in hot flashes. In the SSRI category, both citalopram and escitalopram have been studied with about a 50% reduction. So especially if a patient has a concurrent mood disorder, I think it's really important to consider initiation of an SSRI. Another one I want to highlight is gabapentin. And last week, I actually started a patient on gabapentin. It maybe has more side effects than SSRIs, but can also be effective at 900 milligrams, about a 50% reduction in hot flashes. The problem is, as most of you have experienced, getting patients up to 900 milligrams can be challenging. Other options include clonidine, which is shown to have about a 20% reduction in hot flashes and might be a good choice for hypertensive patients. And then I always tell patients about behavioral changes that they've probably already tried: wearing layers, using portable fans, and then limiting alcohol, smoking, caffeine, and spicy food. I want to wrap this up by talking about comparing and contrasting these different treatment options. And this is just a meta-analysis showing non-hormonal versus hormonal treatment options for hot flashes. And at the top, you can see that estrogen and progestin therapy is the most effective at reducing the number of hot flashes per day, but these other agents are also effective and worth discussing with patients who are not eligible. Where do SERMs fall within HRT? I would have to look that up in more detail, Terrence, but usually, if someone is on something like tamoxifen, they are likely having more symptoms and would not be eligible for HRT because it's blocking those receptors. And probably the reason that they're on the SERM, they also should not be getting hormone replacement therapy, but could use some of these alternate agents. Someone please correct me if their understanding of this is deeper than mine. Thank you, Roxanne. I also want to make sure that we take some time to talk about the safety of hormone replacement therapy. And this is really the highlight. When I was talking with Luke about this, he was like, oh, I would never prescribe someone with HRT. And I think it's actually really important to talk about that reanalyses of these women's health initiative studies have shown that it's safer than kind of originally thought in the early 2000s. So this is data from an ACOG study or an ACOG bulletin about HRT, talking about the different risks of different conditions on estrogen and progestin therapy versus estrogen alone. And this was a reanalysis of that WHI data stratified by age. So I really want us to look at that 50 to 59 age group where those hot flash symptoms are going to be most severe. And there you can see that there is not a statistically significant difference in many of these commonly attributed conditions to HRT in this age group. So CAD, all-cause mortality, stroke, breast cancer are at much lower risk in this age group, less than age 60. And this was a big study, right? This was a study of over 30,000 people. And so I think that this reanalysis is really powerful to suggest that these medications are safe in the right patient population under age 60. And that's why that recommendation of under age 60 within 10 years of menopause really comes from that. I want to talk very briefly about kind of specific risks too in this age group less than age 60. So coronary artery disease, no increased risk in women less than age 60 without a previous history of CAD. For venous thromboembolism, there's no increased risk with transdermal estrogen. So estrogen patches, because it bypasses that first pass metabolism of the liver. There is a very minimal increase in strokes per 1,000 women per year. And then breast cancer risk is also surprisingly low. So after 5-ish years of combined therapy or up to 7 years of estrogen alone, there's less than 1 additional breast cancer per 1,000 women years. So this safety profile is actually pretty compelling to me that in patients who are significantly debilitated by these hot flashes, HRT can be a safe option for them. Molly has a great point. For patients who have had early surgical or chemical menopause, HRT does not increase risk of endometrial cancer. It's actually a relatively lower amount of hormone than physiologic, and I agree with that. Okay, we're going to move back to our case. Flo's desperate for help with her sleeping problem. She knows it's impacting her overall happiness, work productivity, and her relationship. So just to review what we just covered, what are those questions that we want to ask her before discussing treatment options? What things do we want to make sure that we know about her? Medical history, Becca, I totally agree. Smoking, Kevin, great. Does she have a uterus? I also like to know about her family history, getting back to Sarah's talk. What is her risk of breast cancer overall? And then other comorbidities like mood symptoms or chronic pain that might sway us more toward a adjunctive treatment option to help her symptoms. You guys are so good. So this brings us to takeaway number 2, that hormone replacement therapy improves vasomotor symptoms and is safe in most patients under age 60 within 10 years of menopause. Next, I want to move into the genitourinary syndrome of menopause, which is another very, very common condition that patients complain of after menopause. It's a very diverse presentation that encompasses both vaginal and urinary symptoms. It's very common and underreported. And I would argue that all of you should be asking your postmenopausal patients about this during wellness visits, as delays in treatment worsen symptoms and outcomes. This was previously known as vulvovaginal atrophy. You might have heard about it as that, but the powers that be decided that atrophy is probably not the most powerful thing to say to a postmenopausal patient, and society doesn't like to say vagina, so it was renamed GSM in 2013. Again, this is very common. This is that same study, but up to 77% of women between ages 55 and 65 reported vaginal dryness, and over 40% reported vaginal pain. And there's lots of treatment options for this too, both hormonal and non-hormonal options. For non-hormonal options, we recommend vaginal lubricants and vaginal moisturizers that are available over the counter, and regular sexual activity may slow progression. There's also options, going back to Roxanne's talk, about pelvic floor physical therapy that can help kind of relax the pelvic floor and retrain those muscles. But there's also hormonal options that can resupply that area with estrogen. And the reason that these symptoms are happening is that the genital tract and the urinary tract have very high estrogen rates of estrogen receptors. So during this process of estrogen withdrawal, that tissue atrophies. So replacing that estrogen is one of the most effective ways. And even patients with a contraindication to systemic hormone replacement therapy are eligible for vaginal estrogen at appropriate dosing, because there is low to no systemic absorption of vaginal estrogen. There's multiple treatment options that I've shown here. Most common, in my opinion, are the creams that you apply with an applicator. 2 common brands are Estrace or estradiol, and Premarin, which is conjugated estrogens, and usually insurance will cover one or the other. If someone is reluctant to be placing a cream in their vagina, there's also a pill form, which you can see in the upper left, that's also applied with an applicator. And there's also a ring that you can use that I'm going to be trying to prescribe more. That is a low dose, local only estrogen ring that is left in for 12 weeks, which can be really convenient. With the ring, there are lots of different rings. There's the Nuva ring for contraception. There's actually a ring for systemic hormone release. And then there's also a ring just for local hormone release. So I'll provide a table at the end of this talk talking about their different brand names, and just be careful for that. But I would just talk with the patient about the delivery method that they would feel most comfortable with and prescribe that. So Flo comes back 10 years later after successfully treating her hot flashes with HRT. She has since tapered off systemic therapy and comes back for a general wellness and reports doing well overall, but when you ask her about GU symptoms, she reports significant vaginal dryness and pain that's limiting penetrative sex. So how would you counsel Flo about her symptoms? You guys are good at menopause. You'd say, this is also a common symptom. GSM gets worse. Let's treat with your favorite option. Use lube, consider estrogen. I totally agree, guys. I think that this is one of those, there's, at least in counseling my patients, the HRT debate, there's still a lot of misconception about the safety of HRT. And I totally respect that patients don't want to take systemic hormones. But I think local estrogen therapy can be very, very safe and well tolerated in most patients. And patients report a dramatic change in their symptoms with this very safe therapy. So I empower you to all feel comfortable and have the takeaway of saying that topical estrogen therapy is safe and effective at treating GSM, even in patients with a contraindication to systemic hormone replacement therapy. And that you should be thinking about the patients that might be eligible for this. Cody is being super helpful in providing an interesting take on HRT safety that we can do some homework for. There are a lot of interesting critiques of the WHI interpretation. And it's totally true, Cody, like I bet that this is going to be a continued area of exploration, especially as the baby boomers continue to age. And it's going to be interesting to think about, are we choosing the correct doses? Are we choosing the correct therapy? And how long should we be treating for therapy? I think the main takeaway that I have from this is like the validation of patients' symptoms and doing our best to help symptoms that can be extremely debilitating for their life. Becca, a question about HRT. Once they are 10 years out from menopause, does it need to be stopped? We would recommend stopping it if they're 10 years out from menopause. Generally speaking, I think about having them on it for kind of a 1 to 3 year period and then trying to taper it off, given that most patients experience an improvement in their hot flashes by 4 years after menopause. There's lots of different suggestions on how to taper this down. A common thing is looking at their estrogen dose that it's probably in a patch form, and then decreasing every year or every 6 months to the lower form. And then by the time they're on like 12.5 or something like that, then you can try discontinuing it. Some patients don't do very well for this, but between all of us on academic half day, some providers actually recommend cutting the patches down into smaller and smaller pieces and trying to taper people off of them. But if someone is still on it 10 years after menopause, who doesn't have another indication for like systemic estrogen therapy, I would definitely take them off of them by that point. The last thing I really want to highlight to you guys is this table that, if you'd like to take a screenshot or a picture of, has a really, really great summary of all of the different options and their brand names of treatment options. And I've highlighted some of the common ones. So my recommendation, if you're initiating someone on HRT, would be to start them on an estradiol patch. Often we start at 0.075 or 0.05. And then up titrate if they have more symptoms, knowing that higher doses is associated with higher rates of VTE and other things. And then for a progestin, I generally give an oral progesterone pill, which is generally tolerated well. There is a combination patch, a combination estrogen and progesterone patch called a combi patch, but I have yet to have someone's insurance cover that, but that can be convenient for someone with good insurance. I'm sure like the VA has its own thing that they like for you guys to prescribe. And then the last one is the vaginal estrogen options. We talked about estrase and Premarin, but the tablet is called Vagifem, and there is a generic form of the tablet. And then the ring is called Estring, which is something I'm going to try to work on prescribing more for patients. Okay. I'm going to move on, but feel free to take a picture of this or get in touch with me, and I would be happy to send this along. I thought this was a really great review. Briefly, I know we're running out of time, but briefly, I want to talk about alternative therapies which patients often bring up. Common ones discussed are omega-3 fatty acids, phytoestrogens, herbal agents, and the summary is that RCTs have been done, generally with smaller groups of people, but there has not yet been an RCT that demonstrates that these are effective at treating vasomotor symptoms. So patients who are on them may notice a benefit, and that's great. But if someone's talking about this versus, an SSRI, and they're debilitated by their symptoms, I would probably recommend something that is evidence-based. I will briefly say that someone with taking a soy derivative or like what is it called that the naturopaths do when they compound these hormones, though someone with a contraindication to estrogen should not be taking a soy derivative or a conjugated estrogen. And I also wanted to take a moment before the end of this talk to just highlight why I think this should matter to all of you, kind of through a lens of disparities. And I was thinking, there is data to suggest that Black women experience menopause symptoms earlier and hot flashes for longer. But instead, in addition to that, I want you to think that this is half of your patients are going to be experiencing menopause at some point in their life. And you as an internist are well equipped to help treat those symptoms. And it's not just treating their symptoms, it's also normalizing the experience of menopause and normalizing the common symptoms, because I think that can be a powerful thing for you to do as a provider. There's a lot of misinformation on the internet about menopause and treatment options. And as our population ages, I think it's really important for us to be able to talk about this topic that's previously taboo. We owe it to our patients to be able to educate them about this common condition. So next time you see a woman between age 45 and 60 for a wellness visit, I really encourage you to ask her about menopause and common symptoms and validate her experience. Terrence, going back, how often do I find myself ordering FSH or AMH? I have ordered FSH in someone who's like, I think I'm in menopause, but I haven't been having that many symptoms, but I haven't had a period in like 8 months. I think if someone would like kind of the reassurance that they're nearing that, it can be helpful to order. But I really let kind of the patient's concern guide me. AMH is also used in terms of like fertility counseling and can be used in someone who is kind of interested in learning more about their fertility too. So the takeaways that I want you guys to take away from this talk is that symptoms of perimenopause and menopause are diverse and can have a significant impact on quality of life. HRT is safe for most women under age 60 and within 10 years of menopause. And topical estrogen therapy can be used long-term, so long after this pre-60 years mark, and is safe and effective at treating the genitourinary syndrome of menopause. Some acknowledgements, if you guys want more women's health, there is a women's health elective where you get additional training in gyne, family planning, breast clinic, and then get to rotate through our women's clinic. And I want to say a special thank you to my fantastic co-residents who have helped me with this talk. And many of these slides were adapted from slides by Addie McClintock and Amy Berenstein, who are two awesome faculty at the Women's Healthcare Center. These are some resources. I always recommend ACOG bulletins if you have a question about women's health, and then Nature writes a number of fantastic review primers if you're interested more in the basic science or physiology of some of these conditions. I appreciate your guys' patience through this rapid fire talk about menopause, and I would be happy to answer some questions before we all wrap things up. Thank you, Becca, for being here.
Thanks, you guys. This was so great. You know where to find them if you have any questions. But otherwise, thanks all for your engagement and participation. This has been a really fun morning, and we will see you next week for our next academic half day.